We'll be breaking down all major concepts covered on the exam. So picture this. You are in the emergency department, right?
Okay.
And a patient rolls in complaining of a blinding worst-of-their-life headache. They've got photophobia, a rigid neck.
Right, so you're immediately thinking subarachnoid hemorrhage or maybe bacterial meningitis?
Exactly. So you grab your kit, you prep the patient's back for a spinal tap, and then boom, you realize you almost made a fatal mistake. Welcome to the Deep Dive. I'm Harvey.
And I'm Zana. We are MCCQE reviewers, and, well, our goal today is to help Canadian medical students like you feel, completely comfortable with the clinical reasoning and procedural logic you're going to need for the exam.
Before we really jump in, a quick but crucial note. Today's Deep Dive is based on reliable StatPearls articles. This is strictly for medical education, not medical advice. Any clinical decisions you make out there on the wards, they need to involve a qualified healthcare provider.
Yeah, that is our mandate. So today's high-yield topic from section S08 Neurology is the lumbar puncture, the LP.
The classic spinal tap.
Right. It's the absolute gold standard diagnostic procedure for confirming meningitis, subarachnoid hemorrhage, inflammatory conditions like MS, and measuring intracranial pressure.
Which is funny because Heinrich Quincke developed it way back in the late 19th century, and it's still the gold standard today.
Yeah.
But let's go back to that ER scenario I mentioned.
Yeah.
Why would prepping that patient for an immediate LP be, potentially fatal mistake?
Well, on the MCCQE, deciding when not to do a procedure is often the exact mechanism they use to test your clinical safety. We really need to talk about the mechanics of cerebral herniation.
Right, because the central nervous system is essentially a closed box, isn't it?
Exactly. The skull and the spinal column, they hold a fixed volume of tissue, blood, and cerebrospinal fluid. So if a patient has a mass in their brain, say a tumor or a massive abscess or an active bleed, the intracranial pressure inside the skull is going to be dangerously high.
And if you go down to the lower back and puncture the dural sac with a needle, well, you're suddenly creating a low-pressure release valve.
Yeah, you create a massive pressure gradient. The high pressure in the skull desperately wants to move toward the low pressure in the lumbar spine.
Right.
And when that happens, the brainstem can literally get sucked downward through the foramen magnum at the base of the skull. That's cerebral herniation, and, it is catastrophic.
Which brings us to the dreaded head CT rule. We can't just tap everyone.
No, absolutely not.
We have to definitively rule out increased intracranial pressure first.
Mm-hmm.
So on an exam question, what are the specific red flags in a patient vignette that mandate a head CT before you even, touch a spinal needle?
Well, you're screening for any clinical signs that point to an existing mass effect or elevated pressure. That includes an altered mental status, any focal neurological deficits on your physical exam.
Or a new onset seizure, right?
Right. Or if you look into the patient's eyes with an ophthalmoscope and see papilledema, swelling of the optic disc.
But it's not just the physical exam.
Yeah.
The patient's history can also force your hand into ordering that CT first.
Oh, totally. Patient demographics and medical history are highly testable triggers. Like if the patient is in an immunocompromised state, say uncontrolled HIV, or they're on immunosuppressants, they're at a much higher risk for atypical CNS infection.
Like toxoplasmosis, right? Stuff that creates focal masses.
Exactly. You also need a CT first if they have a known malignancy, a history of focal CNS disease like a prior stroke, or simply if they are older than 60.
Yeah, that age cutoff is a classic exam distractor. If you get a question with a 65-year-old patient who has new onset seizures and a fever, the next best step is not the LP to check for meningitis.
No, it's the head CT. You have to secure the anatomical safety of the brain first.
Okay, so let's assume the CT comes back completely clear. There's no mass effect.
Yeah.
We still have to evaluate the patient's systemic ability to tolerate the fatal trauma of the needle.
Right, which is where we look at contraindications, specifically coagulopathies. You cannot perform an LP on a patient with severe bleeding disorders, hemophilia, or von Willebrand disease.
Okay, I have to push back here on the clinical reality versus the textbook numbers because the MCCQE loves to test you on the lesser of two evils.
They really do.
So say our ER patient is crashing with suspected bacterial meningitis. It's life or death. But you pulled their CBC and their platelets are sitting at 18,000. Are you really telling me we just abandoned the diagnostic gold standard?
We do. We abandon the procedure at that number.
Wow, okay.
Yeah, the hard stop for platelet count is strictly less than 20,000. If you puncture the epidural venous plexus in a patient with platelets at 18,000, they will develop a spinal epidural hematoma.
And that expanding blood clot compresses the spinal cord.
Exactly, which causes permanent, irreversible paraplegia. So the diagnostic delay is the lesser evil here. You do not do the LP. Instead, you immediately draw blood cultures and start empiric broad-spectrum antibiotics.
So under 20,000 is an absolute no-go. What is the safe zone then?
Ideally, you want a platelet count greater than 50,000 for a routine, safe procedure.
And what about iatrogenic coagulopathies? I mean, I'm thinking about patients on the wards receiving anticoagulants like heparin.
The rule of thumb for heparin is the 24-hour window. If a patient has received unfiltrated heparin or low molecular weight heparin in the past 24 hours, the lumbar puncture is strictly contraindicated.
Because it's a pharmacological half-life.
Right. You must wait out that window to clear the bleeding risk. And of course, the other absolute contraindication is any localized skin infection right at the insertion site or obvious vertebral trauma.
Okay, so let's transition to the bedside. We've cleared the CT. The platelets are at, let's say, 60,000. No heparin, clear skin. We are greenlit to proceed.
Awesome.
Now, I see residents do this procedure with patients sitting upright on the edge of the bed, slumped over a bedside table all the time. But the literature heavily favors the lateral recumbent position. Why the discrepancy?
Well, sitting up is sometimes chosen because it can make finding the midline of the spine slightly easier, especially in obese patients. But the lateral recumbent position, where the patient is lying on their side, is vastly superior for one major physiological reason.
Which is?
It's the only position that allows you to accurately measure the opening cerebrospinal fluid pressure.
Oh, right. Because if they are sitting upright, gravity introduces a massive hydrostatic column from the fluid in the brain all the way down to the lumbar spine.
Exactly. The pressure reading at the needle hub will be artificially sky high. In the lateral recumbent position, the spinal canal is parallel to the floor, which neutralizes that hydrostatic gravity effect.
So it gives you a true reflection of the intracranial pressure.
Yeah. Plus, lying flat has been shown to reduce the risk of the post-lumbar puncture headache.
That makes sense. Now, to get the positioning right, the patient needs to assume a tight fetal posture. The common instruction is to tell them to arch their back, like an angry cat.
I love that analogy.
It's so vivid. And if we think about the geometry of the spine, the logic here is brilliant. By flexing the vertebral column forward, the posterior elements of the spinous processes, are forced to splay apart.
You are literally widening the interlaminar window. You're creating a larger physical target for your needle to pass through without hitting bone.
Okay, so once they're curled up and parallel to the table, we have to find our anatomical landmarks. And this is where precision is just non-negotiable.
Totally. You start by palpating the superior aspects of the patient's iliac crest, the top of the hip bones. Then you draw an imaginary line connecting those two crests across the back.
That's the intercostal line, right?
Yeah.
Or the tuft ear line.
Yep, the tuft ear line.
And where exactly does that line intersect the spine?
Well, in a standard adult, the intercostal line intersects right at the L4 spinous process, or the L4-L5 interspace. But, and this is a big but, for the wards in females or obese patients, anatomical variations mean that line might actually sit a bit higher, sometimes around L3.
Which brings us to the most critical anatomical constraint of the entire procedure. We are aiming to insert our needle at either the L3-L4 space or the L4-L5 space. Why are we so obsessed with staying that low? Like, why not L2-L3?
It all comes down to the conus medullaris, which is the solid terminal end of the spinal cord. In a typical adult, the solid cord ends at the L1 vertebral level.
Right, so if you insert a needle above L1,
you run the huge risk of piercing the actual spinal cord, causing catastrophic neurological damage. By targeting L3, L4, or lower, you are operating entirely in the cauda equina.
And the cauda equina is just a bundle of loose nerve roots floating in a pool of cerebrospinal fluid. So if a blunt needle enters that pool, those loose nerve fibers naturally just kind of float out of the way.
Exactly. You stay below L1 to save the cord. Oh, and a crucial pro tip for your clinical practice.
Yeah.
Once you find that L3, L4 interspace, take a skin pen and mark the exact site before you prep the skin and before you inject the local anesthetic.
Well, because the lidocaine creates a wheel, like a bubble of fluid under the skin.
Yeah.
If you haven't marked your spot with a pen, that swelling is going to completely obscure the bony landmarks you just spent 5 minutes trying to perfectly palpate.
You will lose your target entirely. So the patient is flexed, the spot is marked. Now we move to the sterile tray. When choosing your equipment, the most important decision is the type of spinal needle. You generally choose between a Quinnick needle and a Whittaker needle.
The Quinic is the classic, named after the pioneer of the procedure. But it's a cutting needle, right? The tip is literally a microscopic blade.
Yeah, and current guidelines strongly recommend abandoning the cutting needle in favor of the Whitaker needle. The Whitaker is a pencil point atraumatic needle. Instead of slicing through the dural membrane, it separates the fibers.
Which results in significantly fewer dural leaks and complications.
Exact.
But because the Whitaker is a blunt pencil point, it's not sharp enough to easily pierce the tough outer layers of the patient's epidermis and dermis on its own, right?
Right, that is the trade-off. You actually have to puncture the skin with a standard, shorter needle first to create a pilot hole, and then you slide your long Whitaker spinal needle through that initial track.
Okay, let's talk about the mechanics of inserting that spinal needle, because the orientation of the needle hub is heavily tested. The needle has a stylet sitting flush inside it to keep it rigid. When you advance the needle, the bevel needs to be oriented in the sagittal plane.
Meaning, if your patient is lying in the lateral decubitus position, that bevel has to face the ceiling.
Why is that particular orientation so vital to minimizing complications?
Well, let's think about the microscopic anatomy of the duramater. The fibers of the dural sac run longitudinally. They run parallel to the long axis of the spine, up and down.
Okay, so think of those fibers like the vertical strings of a beaded curtain. If you orient your bevel facing the ceiling, the tip aligns with those vertical fibers. As it pushes through, it slips between the strings of the beaded curtain, gently parting them.
Right. But if you turn the bevel 90 degrees, so it faces the patient's head, it acts like a horizontal blade cutting perpendicularly right through those longitudinal fibers. You want to part the fibers, not sever them, because parted fibers will snap back together and seal the hole once the needle is removed.
That makes total sense. So the bevel faces the ceiling, you insert at the midline, you angle the needle approximately 15 degrees cephalad. A great visualization technique is to imagine aiming the needle tip directly toward the patient's umbilicus.
Yep. And the distance from the skin down to the epidural space in a normal adult is roughly 55 millimeters, which is about 2/3 the length of your standard spinal needle.
Okay.
As you push smoothly inward, you are waiting for a very specific tactile feedback.
The famous pop.
Oh.
But what exactly are we popping through?
You are passing through the ligamentum flavum. It's a dense, highly elastic connective tissue that runs between the lamina of the vertebrae. It is thick and rubbery.
So you'll feel continuous firm resistance as you pass through the interspinous ligaments, and then suddenly, a distinct give.
Right, a popping sensation as you pierce the ligamentum flavum and enter the epidural space right before crossing the dura into the subarachnoid space.
And once you feel that pop, you don't just shove the needle the rest of the way in. You advance meticulously in 2-millimeter increments. You pull the stylet out, check the hub for clear fluid, and if you see nothing, you put the stylet back in, advance another 2 millimeters, and check again.
But what happens if you don't feel a pop and instead you hit a brick wall? Like, what if you hit bone?
Yeah, the immediate panicked instinct of a tired resident is to just keep the needle deep in the patient's back, angle it upward a bit, and try to force it around the bone.
You must absolutely never do that. If you encounter bone, you have to withdraw the needle almost all the way out, pulling it back into the superficial subcutaneous tissue before you redirect your angle.
Let's unpack the anatomy of why sweeping the needle while deep is so dangerous.
Well, the epidural space is filled with dense, highly vascularized venous plexuses. If you try to redirect the needle laterally while deep in the tissue, that rigid metal shaft will act like a windshield wiper, lacerating those veins.
Oh, wow. And then you induce a traumatic tap. Suddenly, the cerebrospinal fluid flowing out of your needle is bright red with blood.
Exactly. And if you're trying to diagnose a subarachnoid hemorrhage, a traumatic tap completely ruins your diagnostic clarity because now you don't know if the blood is from a brain bleed or from the vein you just clipped.
Right. And if the needle gets clogged with blood, you have to pull it completely out and start over from scratch at a different interspace.
Yeah.
Now, if the standard midline approach is repeatedly failing, perhaps the patient has severe scoliosis or heavily ossified ligaments from degenerative disc disease, the literature outlines a paramedian approach.
Yeah, the paramedian bypasses the midline obstacles. Instead of going straight between the spinous processes, you move your entry point 1 centimeter inferior and 1 centimeter lateral to your L4 landmark. From that offset starting point, you angle the needle 15 degrees medially toward the spine and 15 degrees cephalad, sliding in sideways, to bypass the calcified midline ligaments entirely.
That's a great backup. So let's assume the insertion is successful. You remove the stylet and clear beautiful cerebrospinal fluid begins welling up in the hub.
The best feeling.
The very first step of fluid collection is attaching the manometer with a flexible three-way valve to measure the opening pressure.
And again, this is only accurate because our patient is lying on their side. A normal opening pressure ranges from 6 to 25 centimeters of water.
And as you watch the fluid rise in the plastic tube, you will actually see the fluid level bouncing up and down rhythmically, right?
Yeah, those are pulsatile variations syncing with the patient's respiratory cycle. The venous pressure changes in the chest during breathing are transmitted all the way up to the intracranial vault and down the spinal column into your manometer. So cool. Once you document the pressure, you disconnect the manometer and let the fluid drip into 4 sequentially labeled vials. Now, the MCCQE will test you on the methodology of this collection. There is a golden rule. Never, ever attach a syringe to aspirate the fluid out faster.
Never. You must allow the CSF to drain passively. If you apply negative vacuum pressure by pulling back on a syringe, you risk sucking a delicate nerve rootlet directly into the sharp bevel of the needle.
Ouch.
It causes excruciating pain and can permanently damage the nerve. Passive dripping only.
So you collect about 1 to 2 milliliters per vial. Tube 1 goes to cell count, Tube 2 for glucose and protein, Tube 3 for gram staining culture, and Tube 4 goes back for a second cell count to compare against Tube 1 to rule out a traumatic tap.
Perfect.
So the fluid is collected, the stylet goes back in, the needle comes out, bandage goes on. Are we in the clear, or what complications are we monitoring for? Well, we already discussed the catastrophic risk of cerebral herniation. We also monitor for infection, but we must heavily monitor for spinal hematomas, particularly in patients with borderline coagulation profiles.
Right.
If a patient develops a spinal epidural hematoma, they will typically complain of acute, severe back pain, followed by entirely new neurological symptoms, like numbness or profound weakness in their legs.
And the definitive diagnostic step, if you suspect that hematoma, is an immediate MRI of the spine to locate the compression.
Exactly, though that is the worst-case scenario. However, the single most common clinical complication, the one you will manage routinely on the wards, is the post-lumbar puncture headache.
The positional headache. It gets worse when they stand up and better when they lay down. The mechanics of this headache are fascinating. It happens because the puncture hole in the duramater doesn't seal properly.
Right. Cerebrospinal fluid continues to slowly leak out into the epidural space.
And this ongoing leak lowers the total fluid volume inside the skull. So when the patient stands up, the brain physically sags downward, creating painful traction on the meninges.
Which is why we use an atraumatic pencil point Whitaker needle to minimize dural tearing. We use a smaller gauge needle to make a smaller hole. But there is one mechanical step the physician must take right before the procedure ends to drastically reduce the risk of this headache.
You must put the thin metal stylet back into the needle before you pull the needle out of the patient's back.
Which is just wild. Let's explore the microscopic physics of why that works. I mean, why does replacing a metal rod prevent a fluid leak hours later?
It comes down to the arachnoid mater, the delicate membrane sitting just inside the dura. When cerebrospinal fluid is actively flowing out of the needle hub, the current can actually suck a microscopic strand of the arachnoid membrane into the tip of the needle.
Oh, wow. So if you pull the needle out of the patient's back with that arachnoid tissue still trapped inside the tip, you drag that strand out through the dural hole.
Exactly. That strand of tissue gets lodged in the puncture tract and acts like a wick, constantly drawing cerebrospinal fluid out of the subarachnoid space long after the procedure is over.
But if you slide the solid metal stylet back down the needle shaft before you withdraw, the stylet mechanically pushes that arachnoid strand out of the needle tip and back into the subarachnoid space where it belongs.
It clears the pathway so the dura can snap shut cleanly.
Proper technique from start to finish mitigates almost all of these complications.
All right, let's recap the critical takeaways for the exam. We established the hard stop of platelets under 20,000 and the 24-hour heparin rule to avoid spinal hematomas.
We mapped out the red flags that demand a head CT-like focal deficits, altered mental status, and age over 60 to prevent cerebral herniation.
We visualized positioning the patient to widen the interspinous space, emphasizing the need to stay below L1, ideally at L3, L4, to protect the corsum medullaris.
We explain the necessity of orienting the needle bevel parallel to the dural fibers, the absolute rule against aspirating fluid, and the physics of replacing the stylet to prevent an arachnoid wick and the resulting post-LP headache.
Navigating the theoretical knowledge alongside the mechanical realities of the procedure really makes the clinical reasoning highly memorable for the exam. To wrap up, I want to leave you with a thought to ponder on your own that builds on all this fluid dynamic stuff we just talked about.
Yeah.
Think about the fact that Heinrich Koenig mapped out the fluid dynamics of the brain and spine using pure anatomical deduction and observation. He developed and successfully performed this procedure in 1891.
1891. That's incredible.
He didn't have CT scans.
Yeah.
He didn't have MRIs to check for hematomas. Imagine being the first physician to pitch this to a patient. I'm going to slide a long needle into your spine to tap the fluid surrounding your brain.
The sheer audacity of that clinical leap is just staggering.
And yet, over 130 years later, with all our modern technology, we still haven't found a better, more definitive way to diagnose these life-threatening conditions. And we are still using those same mechanical principles like replacing a simple metal spilet to manipulate microscopic fluid dynamics on a cellular level.
It's a remarkable testament to the enduring power of foundational anatomical knowledge.
Truly. Thank you for joining us on this deep dive. Keep practicing your clinical reasoning, keep questioning the mechanics behind the procedures, and good luck with your MCCQE prep.